يا شباب هل الصوت مسموع عندكم؟ هل الصوت مسموع عندكم؟
دكتور لوكاس.
Yeah.
دكتور محمد, please introduce Prof Lucas.
هل الصوت مسموع عندكم؟ لأنه احنا تسمعوا الصوت واضح؟ دكتور خالد, did you hear me?
I can hear you. Is the video?
Also, Professor Lusuardi, I hear you clearly, but I don't know if the people in the floor hear us or not.
Ah, that's good. Is the video with audio?
Yes, yes.
Okay. So maybe you can start it.
Dear colleagues, welcome to this ESUT lecture. Let me please introduce this topic. But before that, let me please thank Professor Algorlani for the kind invitation. And I'm very happy and delighted to be virtually with you. Urothelial carcinoma of the bladder is getting an increased problem in all countries because we have an aging society, increased diagnostic possibilities, and this produces costs. The resulting increase in therapy costs drives all our health systems to the limits due to obvious limited resources. That's why already now the bladder carcinoma belongs to the most cost-intensive tumor entities because of the average cost per patient. Although 70% of all newly diagnosed urinary bladder cancer are histologically primary non-muscle invasive bladder cancer, due to their propensity to recur and the specific risk of progression, the combination of these facts make them to a huge socioeconomic burden. Actually, our management for non-muscle invasive bladder cancer has not changed significantly throughout the decades because we are still doing routine controlled cystoscopies. Our bladder tumor resection is unchanged in the last 70 years, and we still are doing instillation therapies. Probably immune therapy is the novelty of the last couple of years. And our current gold standard in the treatment of non-muscle invasive bladder cancer has not changed. It's still transurethral bladder tumor resection. In the last 2 decades, we have faced 2 novelties which regard technique and technology, because we had the advent of bipolar TURP, and we faced the novel concept of Enblock bladder tumor resection. Talking about monopolar versus bipolar TURP, in one of 4 existing meta-analyses, we could define a difference in efficacy propending for bipolar TURP, producing shorter operative time, less bleeding, and therefore less catheterization time. In the same meta-analysis, the authors also concluded that bipolar had some fewer complications because of a slightly reduced obturator nerve reflex, producing less perforation. Obviously, it's only one meta-analysis which demonstrates a superiority of bipolar versus monopolar. But surely one thing completely disappeared with bipolar technology, and it is TUR syndrome. Looking at the different physical properties, obviously you can see difference in voltages, in penetration depth, all in favor of bipolar technology, being a quarter or a fifth in penetration depth in comparison to monopolar tumor resection. Again, in this slide, you can appreciate the huge differences in power and penetration depth, and even heat on and its manifestation on tissue due to the different technologies, all I would say in favor of bipolar resection. Does this mean that monopolar technology is going to disappear? Well, I'm not sure. I don't think so, because obviously colleagues being able to have high performance resection, bladder of prostate with monopolar technology still exist and will continue in their work with great functional results. And we also have to consider that there are differences in country and in economics, and even differences between public and private setting, where economical aspects make some difference and really matter, and where the advantage of being cheaper as for monopolar may produce significant advantages. We also have to consider that our gold standard of bladder tumor resection still represents an incise and scatter technique, which means that the tumor which excites the length, the width of the loop produces fragmentation. That means we are one of the only specialties, surgical specialties, destroying tumors to retrieve them from the human body. And we even produce this kind of treatment only for non-muscle invasive bladder cancer, because we wouldn't dare to destroy a prostate doing a prostatectomy, or destroy a kidney cancer doing a partial tumor nephrectomy. The surgical technique itself is therefore suspected of being involved in cell seeding and producing the recurrence outside the recurrence area because of the cell seeding. We are also aware that the accuracy of our initial procedure, of our initial TURP, is decisive for the further prognosis of the patient. Therefore, consequently, we know that the absence of the trusor in the histopathological specimen, especially in a high-grade first presentation non-muscle invasive tumor, produces a higher incidence of tumor persistence, will produce a higher early recurrence, and will automatically delay radical cystectomy or further treatment, deteriorating prognosis of the patient. And you see that another technique has been already introduced more than 20 years ago, which is the Enblock bladder tumor resection, obviously at that time with monopolar current. But as you can imagine, this is not a new technique. It's now just getting popular because of increasing technology available. In recent years, in addition to the widespread conventional TURP, as you already saw, we have adopted Enblock as an alternative. And as I already mentioned, this has to do with improved technology available on market, different lasers, different current available, and even further application. But basically, regardless of the technology employed, you see the concept remains the same. It is digging underneath the tumor without even touching the exophytic part of the tumor and removing the tumor in one piece. So this is the way we perform Enblock bladder tumor resection.
Oh, it's not moving. Oh, it's not moving. The video is not moving.
Dear colleagues, wealthy increased diagnostic possibilities, and this reduces costs.
Yeah.
The specific risk of still its block. We could produce obviously that our from the cells block different lasers, different piece.
Yeah, now.
So this is the way we perform Enblock bladder tumor resection in my department. I tend to use this rectangular loop. It's a bipolar Karl Storz instrument. It's useful to have a half empty bladder. I tend to use all available imaging technologies, in this case, Image 1S by Karl Storz, switching from one modality to the next one, and mainly not only to discover other tumors in the bladder or small satellites, it's more to understand where the margins of the tumor itself are. The procedure always should start with a circumferential incision of the mucosa. And if you notice, I'm doing very fast, short movement with the cutting pedal. Therefore, the cutting is very easily to control. And you see this rectangular loop, which is bent forward by approximately 30 degrees. It's a nice tool because it combines the quality of a loop. It's bent forward so you can easily reach every part of the tumor. And by rotating it by 90 degrees, it almost resembles a Collins. The concept of incising all around the mucosa is very helpful, because the risk, if you avoid to do that, is to get too long underneath the tumor. You tend to remove too much tissue, even healthy tissue, which is not the goal of our job. The goal should be to remove the tumor with one piece, with a slight margin, which optically, which macroscopically should be in a normal, healthy looking tissue. Having done the incision circumferentially, you just decide the depth, the desired depth, just by doing those small cuts and going underneath the tumor. As soon as you have done approximately the half of the job, the tumor will lift up and tilt up until you have dissected it completely. You can very easily choose how deep you want to get by just doing some deeper cuts. You can really very clearly define how deep you want to get because of this new generator of this bipolar Karl-Stuart system. Here the tumor is always lifted up, so you don't see it anymore, and it's reaching the margin of the resection. And that's why I was telling you it's better to incise it circumferentially. So here you understand I'm finished with my resection and I am done. Otherwise, you risk to remove too much tissue. In this case, we were close to the orifice. We did not insert a ureteral stent because you see the ejaculation of urine. We just coagulate. And here we have the tumor being at the bottom of the bladder. You can either remove it with the loop through the sheet, especially if it's less than 2 centimeters in diameter, or if you want to do it in this way with a bag which comes from gastroenterology, you can even do like this. It's obviously a little bit more complicated because you are working without the help of gravity. And in addition, it's obviously a little bit more expensive because you need a bag. Enblock bladder tumor resection has been already performed with different technologies, as already mentioned before, with monopolar conventional loop, with the J. Collins monopolar, bipolar technology, even with a more complicated instrument, the water injection, and any type of laser. If we go into detail looking at literature, obviously, especially in the last 15 years, we have a development. We have an enhanced velocity of the publications because, as you already heard, technology has driven this successful technique. And in particular, if we look at histology and morbidity and follow-up or recurrences, we can state the following aspects. Well, looking in particular at histology, you can imagine that looking on the left side, that's the standard tumor resection in pieces. And on the right side, the Enblock with the muscle, with all layers in one slide, you will make your pathologist very happy. Looking retrospectively at one of the largest databases in Europe, there could not there have not been demonstrated superiority of one technique over the other. Both energy, mono and bipolar performed very well and were efficient in removing the trusor. which was present in far more than 90% of all cases. So these results really reinforce the assumption that the endoscopic resection of bladder tumor can be improved by the Enblock technique, and this regardless of the energy source. In particular, in this study, laser were equal to mono and bipolar. And taking into account the underlying data, both perioperative and postoperative complication, both are classified as minor. In fact, bladder perforation, clinically relevant bladder complication are really seldom. They are probably because of a bias, because it's experts starting with the Enblock procedure. They are very close to that what we know from conventional bladder tumor resection. In the aforementioned European study, the Clavien 2 complication rate were 5%. It was mainly UTIs. The perforation were 3%. It was just 6 cases out of 221. And even looking at the entire literature, you see perforation rate ranges between 1 to 5% in the available current literature at the research done by myself a couple of months ago. Data on the recurrence frequency provide in 19 of 22 underlying studies were included, but however, they do not follow a uniform protocol, especially the aspect of instillation was rarely included. So we cannot really say anything about oncology, but we can ask our pathologist for the first time to look at the margins of the tumor. At the margin, and this is really a novelty in this tumor entity. So whether the Enblock resection will really lead to the postulated improvement with regard to a reduced recurrence rate because of the avoiding of the tumor spillage cannot really conclusively be stated at the moment. However, the results presented so far at least suggest a non-inferiority to conventional gold standard TURP. And in the case of smaller tumors, however, an improved histological outcome is clear in the Enblock resection due to the reduced thermal effect and due to the presence of the detrusor muscle in over 90% of the cases. That's why conventional TURP still remains the gold standard in the treatment of non-muscle invasive urinary bladder cancer, but the EAU guidance already included Enblock technique as a solution for tumor less than 3 centimeters, where the detrusor is important to be included, where aging, especially looking at the PTA1 substaging, is important for the further prognosis and treatment of the patient. Thank you very much.
So I hope the audio was good enough.
Thank you very much, Professor Lusuardi, for this good presentation and new thing about the Enblock resection of the blood, non-invasive bladder tumor. And now for discussion. Any question for you?
Good morning, Professor Lusuardi. Thank you. Thank you very much for this nice presentation. And we are very, very happy to have you with us in this meeting live. And hopefully in coming meetings, we'll have you visit with us. We will be for this. I have 2 questions about this presentation. First, what is the current you are using? Cutting current or coagulation or TUR mode or both? The second question about the size limit of application of this technique. If we have multicentric lesions or big tumors, is it still applicable, this Enblock technique, and how you will get rid of the specimen also with bag, or you have to use morcellator? Please, we hope to have the answer. Thank you.
Well, I personally use, as you could see from the video, bipolar energy, and the job is done mainly by cutting. You can coagulate the vessels because you see them in front of you. Every time you see one vessel, you coagulate it, but mainly the job is done blunt and with the cutting pedal. Regarding the dimension of the tumor, obviously this is the limit of the technique. And I would also add the fact of the number of the tumors, because if you have a bladder which is full with 30, 40 tumors, it is impossible to do an Enblock of every lesion. So the dimension between 3 and 4 centimeters is the upper limit, in my opinion, because the goal would be the removal of the tumor in one piece and not destroying it, because you want to produce a better histology for the staging, to have possibly also a substaging of the PT1 if you have a PT1 tumor. So the goal is to have a better histology of the one side, and of the other side you would reduce the tumor spillage. So it does not make sense, in my opinion, to destroy the tumor to retrieve it. So you do an Enblock procedure, then destroy it to retrieve it. So the limit is size.
Any question?
Dr. Ibrahim.
Thank you, Professor Lucas, for excellent and interesting lecture. In order to reduce the local recurrence rate in non-muscle invasive urinary bladder cancer, what protocol you adopt to decrease the local recurrence regarding intravesical installation of either Gemzar, and at what time you start that? Either Gemzar or gemcitabine, BCG or mitomycin. At what time you recommend that, and what protocol you are following to decrease the recurrence rate? Thank you so much.
Thank you very much for your question. I think I use the same protocol I use for conventional TURP. We still cannot, we still have to demonstrate with this Enblock procedure that we reduce recurrence. Since we lack this important information, which probably will be available in the next years, because there are several ongoing prospective studies, since we lack this important information, we still have to proceed with our usual protocols. And believe me, Enblock tumor resection for an experienced endoscopist is not more difficult, because you're always working in a clear view, and the tumor is always in front of you. Yeah, the loop is always in front of the tumor. So it's a very controlled procedure with a very limited number of perforation. Therefore, you can do your irrigation or your installation therapy as you are used to.
Any question?
Dr. Muhammad wanted to.
Thank you for this good presentation. I'm asking about the advantage of this technique comparing laser resection.
The advantage of the laser, in my opinion, is especially on the lateral walls, because with laser you absolutely have no obturator jerk. So again, with bipolar technology, you will face less obturator reflex, but you will have one. With the laser technology, regardless if holmium or thulium, this does not really matter, you will have also disadvantage. The disadvantage, in my opinion, for laser is that you have to always work with an instrument which is in front of you. So for special location of the tumor with the laser, it might be a little bit more complicated than with the loop I just showed to you. But the advantage, the clear advantage, no obturator jerk.
محمد مهدي.
السلام عليكم ورحمة الله. هل صوتي مسموع لديكم دكتور إبراهيم؟
تفضل.
صباح الخير عليكم جميعا ونهنئكم أولا بالنجاح الباهر والتنظيم الرائع. I would like to thank the Professor Lusuardi and the Eurotechnology section of the European Urological Association because of their active collaboration and participation. I also extend my thanks to Professor Ali Sardar Gozin, who has recommended Professor Lusuardi as a speaker for the Eurotechnology section. I have one question for Professor Lusuardi. What about a big and bulky tumor? Sometimes you could not get around the tumor because of the bulk of the tumor. Could you do Enblock resection also for these big and large tumors? This is the first. The second question about laser. We have a low power laser, 30-watt laser. Could we use that low power laser to do Enblock resection? And thank you again for your participation, Professor. Thank you for all.
Absolutely. Starting with the second question, there is no limit. Even with a low power holmium laser, you can do a very nice unblock procedure. I would start with an easy position, maybe at the bottom of the bladder or bladder neck, which would be an ideal position for a laser to start with. And regarding dimension, it's not the problem. That you can resect, unblock even tumor which are 10 centimeter. The problem is to retrieve them out of the bladder. There are colleagues working in the concept of radical unblock tumor resection to do a trimodal therapy. We just heard, but a couple of minutes ago, I was listening to Professor Abolenine, and I know his concept, and I am with him with the concept that probably trimodal therapy is inferior to neoadjuvant chemotherapy followed by cystectomy. So if you have an old patient not being able to undergo cystectomy, maybe you can do an unblock procedure to remove the tumor. But if
the tumor is so large, if the tumor is so large, how you can get around the tumor to resect the base of the tumor?
This is not really a problem. You can, the limit is not a problem of the technique. With this loop I just show you, it's a combination of a loop and a Collins knife, so you can go around the tumor without difficulties. The problem is the retrieval of the specimen, not the dimension, but you have to get it out.
Okay, I get it. Thank
you. I want to ask Professor Lusuardi, if the patient indicated for installation of chemo or immunotherapy or both, what is the time? It's like conventional QRP?
Yes, we do it immediately after the procedure in the recovery room, which is half an hour after unblock procedure.
Thank you. Any question?
Excuse me, pardon?
Question for the a new question.
Dr. Aziz Shamsan, third year resident in neurology department. Thank you for your lecture, Dr. Lukas. My question is, we noticed in your video that the ureteric orifice was apart from the tumor. What about if the tumor is so close to the ureteric orifice, and about the rule of double G insertion before the resection in TURBT in overall and in your way specifically?
Well, I tend not to stent ureters even if the tumor is on the orifice itself. I tend just to avoid coagulation, and it might be the fact that I open up a little bit the tunnel of the ureter itself with a Collins knife, but I tend not to insert a double J. There seems to be some evidence that it might increase the incidence of metachronous upper urinary tract carcinoma. So if it's not, if I did not coagulate very much on the orifice, I do not insert anything, and I look at the clinical situation. If the patient develops pain after the operation, then we would insert a nephrostomy.
Any question? Thank you so much, Professor Lusuardi, for your good and new knowledge and presentation. Thank you so much.
Thank you.